reproductive medicine consultant, I thought let's do it in a little different way. So endometriosis and infertility, we all know that it is an agonizing condition. It's a chronic, it's a recurrent disease, and it's characterized by the functional endometrial glands, which are the outside, these all lesions, and they can be superficial peritoneal lesions to the deeper implantation. The prevalence, 10% of a reproductive age group, it suffers. If you see the globally, 176 million women, while in India itself, 25 million women, we have endometriosis with it. Endometriosis, few facts. Infertile woman will have 6 to 8 times more endometriosis than the fertile woman. Endometriosis will have a low fecundity rate, 0.02 to 0.1 per month. This is very important. So if you can't just say you keep on trying and you will conceive naturally, you have to understand the inherent pathology itself will not give them a natural conception. And it is associated, as Muralidhar Pai has just said, lower live birth. So if you have to twinkle with the figures of the woman presented with the infertility, around 25 to 50% will have endometriosis, and of the woman of endometriosis, 30 to 50% will have a infertility. Pathogenic theories, we are all aware of Sampson's theory of retrograde menstruation, and now we are talking about the coelomic metaplasia or genetic or the stem cells and altered immunity, which are becoming now more common. What is important, because why I'm talking about this pathophysiology, if you understand, then you will master your treatment accordingly, because you know what's going on in the patient's body. So it's a chronic inflammation. What do you mean by chronic inflammation, which is the core of endometriosis? There is an activation. Because of these lesions, there is an activation of the macrophages. And these will cause increased generation of inflammatory factors. These are the oxygen nitrogen species, the pro-inflammatory cytokines, the tumor necrotizing factors, the growth factors, the prostaglandin, all these increases, and they will create the adverse pelvic environment. Also, this chronic inflammation will cause proliferation of the tissue, which then lead to pain and infertility. So very, very important for all of us to understand that there can be all these inflammation will give us the adhesion formation, the elevated oxidative stress, the ovarian cyst or the endometriomas, altered immunity, the change in the tubal anatomy, though they are patent, they are swollen and they may not be functional. So anatomically patent doesn't mean physiologically functional tubes. Alteration in the follicular and peritoneal hormones and the abnormal folliculogenesis, and then above all, altered or decreased endometrial receptivity. All this is going to affect from the egg level to embryo formation to the implantation and the continuation. All this is their mechanism. And above all, this is very important slide, impaired progesterone signaling. Why this is important? Because I'm going to come to the role of a dydrogesterone. So remember what happens here is because of endometriosis, there is a disruption in the progesterone and estrogen signaling. And because of their hormonal imbalance, because of their disturbed signaling, there is a suppressed cellular response to the progesterone exposure. So there is a resistance at the progesterone receptor level. And that's why progesterone cannot be acted upon, and the inflammation and all this continues. So progesterone resistance confirms the endometrial tissue, the ability to remain viable at the foreign atmosphere. This is very important. So this is the pathophysiology of what I just told you. And these all cascade gives us either pain or the subfertility. Now, what is important is we all now are understanding the pathophysiology much better than what it was. We are understanding that the progesterone receptor blockage or the resistance of the progesterone, the signaling alteration, even the hormonal imbalance, all these. But the management still is very much controversial. And let me go through it. For women who present with the endometriosis and infertility, very important you take a detailed evaluation. They may not tell you in an unmarried stage, the young stage, they might have undergone surgery, which they might have hidden, or they might have taken some treatment, but it's very important. Also, detailed history is important because when it is endometriosis, we get carried away in one direction, the entire. There may be associated other factors. There may be associated the male factor. So the history, evaluation, and the evaluation of the both partners should go together. Now, choice of infertility therapy depends upon the combination. What you found in your evaluation and what is your surgical staging. Depending upon that, we decide. But there may be a need to perform the primary surgery. And I always say, if the patient is regular cycles, young patient, good reserve, tried ovulation induction, semen was normal, so she might have TIC, that is time intercourse, or she might have IUI, but she did not conceive. On your paper vaginal, when you do, there may be just tenderness in a pouch of Douglas. When you are trying to see the ovary, she quinces. That means there is a pain on a deep palpation. So in such all cases, the laparoscopy, very important to do the staging. It's important we need to do because the treatment differs from what stage we diagnosed. But the repeat surgery is always only for the pain symptoms. Repeat surgery is never for the fertility evaluation. Till now, this ASRM classification from stage 1 to stage 4 was first, initially, we felt it is very difficult, very complicated, but more or less, we termed that stage 1 to 2 is minimal to mild endometriosis. Stage 3, when we call it as a moderate endometriosis, which includes endometriomas and maybe a minor adhesion, which may conceive after your successful laparoscopic surgery. And stage 4 means a frozen pelvis. This we were more or less, but we realized it's lacunae somewhere. And then this enzyme 2020, this classification came into, which gives it a compartment with the retroperitoneal tissue coming in, or with the grade of invasion from 1 centimeter to 1 to 3 centimeter to 3 centimeter, or it depends upon the surrounding organ involvement. It has labeled differently. One thing very important for all of us to understand is endometrioma. We know it has a decreased fecundity, but also there is relatively reduction in the ovarian reserve. So women with endometrioma experience progressive decline in serum AMH level. It is faster than the healthy woman. So you have a 30-year lady with the endometrioma and 30-year lady with the no endometrioma with the AMH of 2.5. If you repeat it after 6 months to 1 year, you will find the lady with the endometrioma might have gone to 1.2 to 1.5, while the other lady may not have so much decline, maybe 2.3 to 2.4. So the faster decline. And why this is important, why I'm stressing for it, so that you understand the need of urgency for the treatment. Don't keep on playing with the patient if they have an endometrioma. Sometimes they come for the routine health checkup and they say, no, we are not planning the pregnancy. I just came for a contraceptive advice. And to your surprise, you find that asymptomatic but big, maybe bilateral or a 7 centimeter endometrioma. It's your job to sit and counsel them that today, probably you are asymptomatic and that's why it gone undetected, but it's a high time that you start thinking about planning your pregnancy. Well, if you have the patient with these recurrence, remember this, every endoscopic surgeon, they feel they are born with the golden heart. Even I may think so, in my hand, I can do best. But when you have such tubes, such frozen pelvis, friends, please, whatever the best endoscopic surgeon you are, ensure that you refer this patient for an ART. Repeat surgery, when the tubes are completely gone, they are frozen. This, I will label it as a stage level 4. In these cases, even the intestine, you can see they are being pulled. The tubes are swollen. Repeat surgery is only if she has a severe pain or very rarely the endometriomas are at very low level and you cannot reach out to the follicles later. Now, to operate or not to operate, a symptomatic patient who has never undergone the laparoscopy and you have diagnosed, this is always a dilemma what to do. Whether I should tell her, keep on trying yourself since you don't have a pain, you have no symptoms. Before I land you up, you are young, can I keep on trying? Or shall I do the laparoscopy and do the not only the excision of the cyst, but also decide the staging? Because many a times you may not be able to see the frozen pelvis unless you are excellent sonologist, where you will see that the bowel movements are not happening. You can see that the thickening of this. You may see invasion of the endometriotic tissue or the pelvic implants into the colon. So all these things, laparoscopy is the best thing. Remember one thing, this is a beautiful article, Cochrane review in 2020. We all know that Cochrane never gives us an answer, but sometimes it does. So laparoscopic surgery increases the viable intrauterine pregnancy rate in endometriosis cases confirmed by ultrasound. However, no data to whether it will improve your live birth. But friends, after laparoscopic surgery, remember the maximum success is in first 6 to 9 months. So the dilemma which happens to everyone's mind, if surgery, am I causing more harm or the help? This is an interesting publication which has given us. So if the surgery is done by the expert, by the reproductive surgeon, I should call it as a reproductive endoscopic surgeon, then this is an article where they studied at 1 month interval, they found the AMH level declining, but at the 6th month, it was low but not statistically significant. So the expert reproductive surgeon can do a good job. But remember one thing, the rate of AMH decline will be correlated positively with the baseline, your AMH value, and the size of endometrioma. And if she has a bilateral endometrioma, then the decrease in AMH is going to be significant. The decision whether to operate or not also depends upon so many factors. It's not only for the staging, you want to do the laparoscopy, but if her age, if it is advanced, if her reserve is decreased, if she has a previous history, I have already told you no role of repeat surgery, associated pain, size of the endometrioma, ovarian access for the IVF, and risk of surgery and the cost of surgery. All this you have to think together. Advanced age, decreased reserve. I may not be even trying to know what is the stage. She's 36 years, AMH 1.4. I'm seeing bilateral endometrioma. I may probably go without surgery unless she has a severe pain. When I have to do the surgery, what are the precautions? I have selected only one video because it is too much of a time consuming, but selected where tubo-ovarian relationship are normal and ovarian endometrioma, when you are seeing, usually it will rupture. So what I do is I don't give a head load to this patient. I always keep a suction in my right hand so that I start before it spreads everywhere. Traction and counter traction, very important. You remain next to the line of a cleavage. Endometriosis is a neoangiogenesis. You will have a lot of capillary oozing. Don't start cauterizing it. So this is a bipolar. Can you see that I'm doing on a cyst wall, and then this is a cortex which I'm going to keep. The cyst wall is tremendously thick. It is going to take out as much of cortical tissue as you can even dream of, but very important. And when you reach to the base is always difficult. So be careful. Don't just pull out because it can bleed torrentially and you unnecessarily can land up doing a cauterization at the ovarian ligament. And next important thing is, can you see that? I don't cauterize. What I'm doing is I will go back there. I don't cauterize. I just put the lavage there. I put a lavage and underwater, I found out any arterial bleed. Venous and capillaries, you should compress it. Now, in these dead spots which you are seeing on infundibulopelvic ligament, you don't have to bother. It is the active lesion. Now, relatively good tubo-ovarian relationship at the end. There was no pelvic endometriosis. I cannot see any capillaries there. I don't see neoangiogenesis. I don't see pseudopouches. I don't see any petechial patches there. So this is relatively a good stage of a case, and I can just think of giving a conservative, asking her to try naturally if she's young. And 6 months, when you say you have to give them a deadline, how long? You can't just say, oh, good, I have done a beautiful surgery, go and now you will conceive. Never do that. You give them how the natural pregnancy happen, what is the time period they should try, the periovulatory period, explain them, and give them 6 months of a period. In 6 months, if they don't conceive, they have to come back to you. So my all standard instruction is either with urine pregnancy test positive, beta HCG positive, or 6 months no conception, they have to visit to me. Now, this is an interesting article. Ovarian endometrioma negatively impacts oocyte quality and quantity, but not the pregnancy outcome in IVF ICSI treatment. This is a retrospective study which has been released in 2021. Why I took it? Because they have said 800. So we do have a ISHRA guidelines which are released in 2022, but we also have a beautiful publication. 862 on one arm and 862 in a control arm is a huge amount, I feel, with a study period of 10 years. Now, what did they say? Very important. Endometrioma affects the antral follicle count. It will affect the AMH. It will affect the ovarian sensitivity index, oocyte maturation, fertilization rate, and the blastocyst rate. Everything will be affected, and number of oocyte retrieved and the available embryos all will be less when you have an endometrioma. Why I'm telling you? Because if you see the publication between 2011 to 13, Tulandi and Garcia, where they have said presence of endometrioma doesn't affect the oocyte and embryo quality. Even in 2004, there is a beautiful publication of Garcia with the equal age group, and he has shown the number of eggs and the number of embryos and the gonadotrophin number needed, the units needed, maybe more, but the rest is normal. But in last 4-5 years, we are seeing the publication saying there will be a oocyte quality, the number of oocyte and fertilization rate and the available embryos are less. But very important that the pregnancy live birth rate are comparable. Very important. We all are needing live birth rate. So they said even if oocyte and embryo quality, they are little bit on a declining side, number of embryos available are less. If you see the live birth rate between the endometrioma and control group, it was the same, regardless of a surgery done or not. So what does the surgery do? Surgery, when they take out the endometrioma, pathological tissue, as much as higher maturation you will get in oocyte quality, higher fertilization, and higher top quality embryo. But the oocyte retrieved will be less. So more or less cumulative pregnancy rate you have to think about, because we probably go for the frozen embryo transfer. And if I have more embryos available, I will be having more cumulative pregnancy rate. So you have to come on to the individual patient and decide what you should be doing. We all have to understand that if I give her M28 oocyte in a non-endometrioma patient, young patient, my embryologist may give me back 7 to 8 embryos, while here I will have maybe 3 embryos or 4 top quality embryos. So the fertilization and cleavage and the blastocyst formation rate will be low. What does the 2022 endometriosis guideline tells us? More or less, I think that is what we are practicing. Operative laparoscopy should be given for a level 1, level 2. That's what we do. Ideally, I always say level 1, level 2, you can identify only when you put in a laparoscope. And around 45% of the unexplained infertility patient, after putting a laparoscope, you will find that there is a early endometriotic deposits or pseudopouches or neovaginas. So you should do operative laparoscopy, means endocoagulation. Or if the patient has a pain, you may do the excision. So endocoagulation is needed than non-endocoagulation. I think way back, 25 years ago, Tulandi's interesting in late 90s, there is a paper where he has done the difference between the stage 1 endometriosis operated by the endofulguration and non-operated, and he found 25% success rate in the IUI rate when you have operated. Clinicians may consider operative laparoscopy for the treatment of endometrioma. It may increase their natural pregnancy rate, and that's why you may think about. No compelling evidence exists that operative laparoscopy for a deep infiltrating endometriosis improves the repair, but there may be associated pain and you may land up in doing it. Is a hormonal or medical therapy effective after the endometriosis-associated infertility? No. We all have to understand the OC pills or the GnRH, whatever we will give, will cause an anovulation to the patient. And hence, no medical line of treatment is allowed for those who are willing to have their pregnancy. Now, but I'm going to speak 5 minutes on dydrogesterone. This is a right choice, not because a lot of companies are coming and they are supporting us, or they may be giving us academic grants for our CMEs. Dydrogesterone, even years together, and sometimes when I read about this publication, I feel, oh my God, I should have made the publication. We never think we are doing it differently. So where do you give a dydrogesterone? The laparoscopic patient which you saw, I give those patients a dydrogesterone post-operatively. Why? Because I believe that dydrogesterone doesn't allow the progress of the disease. I'm going to show you the evidence for it. Also, dydrogesterone doesn't cause anovulation. So laparoscopic surgery, even when I see the mild endometriosis, I have a routine habit of putting the patient on dydrogesterone 10 milligram daily for 6 months till they come back to me. At least I'm relaxed that her endometriosis is not progressing. So how do dydrogesterone helps? Dydrogesterone decreases the pro-inflammatory cytokines and the oxidative stress, which gives endometrial progesterone resistance. Just now I told you there is a pro-inflammatory cytokine increase, there is an oxidative stress even in the ovarian tissue, and there is a progesterone resistance. And this progesterone resistance will not allow the shedding or the good acetylization. So what does dydrogesterone does? It increases the progesterone receptor expression and decreases the pro-inflammatory cytokines. So fantastic. It changes the TH2, changes towards TH2 immunity. And it also exhibit the anti-inflammatory action via decrease in expression of a leukocyte adhesion molecule. Because we all know that peritoneal fluid is rich in the reactive oxygen species, which creates the hostile atmosphere. So dydrogesterone helps in both the way, and it decreases the pro-inflammatory action. It reduces the speed with which the endometriosis will progress. So this is very important. It reduces this tumor necrotizing factor, induced natural killer cell activation. It reduces the proliferation of endometriotic stroma cells. It reduces the wrong interleukins, and it increases the nitrous oxide production, which plays very important role in an anti-inflammation. As anti-inflammatory. So all this is done by dydrogesterone. So please, I tell companies, they are talking only about the luteal phase and dydrogesterone. The entire country is studied with the companies, nearly 25 companies coming and talking only luteal phase. They should promote role of dydrogesterone in endometriosis. And that's because it decreases even the pain symptoms. It improves the quality of life. There is no inhibition of ovulation, as I told you. It doesn't alter your HPO axis. It helps only into the uterine and pelvic atmosphere, and it increases the pregnancy outcome. So hormone replacement therapy or hormone therapy pre and post surgical as an adjunct to surgery. As I told you, women seeking pregnancy should not be. The first 6 months after the surgery, they have a maximum chance of a conception. And those who cannot attempt to or decide to conceive, probably you may put them on OC pill so that their progress will decrease. Now, pre and post surgical medical therapy, this is very important. The Cochrane in 2020 also said that pre or post surgical therapy for suppression doesn't help us to optimize. So don't make them unovulatory. In women with the endometriosis, is surgery effective to increase the chances of natural pregnancy? Yes, probably, if you are in early stages, as I told you already. But if you are doing the surgery, and especially for endometrioma, cystectomy is preferred over the bipolar ablation, the less recurrence. And believe me, if you remain careful, your AMH will not be decreased so fast as against. There are certain people who are doing a CO2 laser. Is the CO2 laser more effective? No. The spontaneous pregnancy is higher after the laparoscopic stripping than anything. So ovarian endometrioma, as again I repeat, it impacts because 2022 ISHRE also has spoken this. These are the ISHRE guideline I'm talking about. Ovarian endometrioma, it negatively impacts the oocyte quality and quantity, but not the overall pregnancy outcome in women undergoing IVF ICSI treatment. So probably you may not be doing, it is not advised who are going for a ART to do. Endometrioma can lower the cumulative live birth by decreasing the number of embryos, and surgical excision can partly improve the oocyte maturation and fertilization because you removed it. But as I said, live birth rate or a pregnancy outcome are not affected. So it doesn't matter. Is ART more effective for infertility associated with endometriosis? Infertile woman, stage 1, 2, you can still think about IUI. I will always suggest IUI with the gonadotrophins, with not oral ovulation, with gonadotrophin. So your success rate will be more better. IRT can be performed directly in if there is a tubal function, you feel it is compromised, or in case of a low AMH, or if other treatment has failed, ART is the option. Specific protocol for ART, it is not recommended. Antagonist and agonist, both the protocol. And those who are, these people probably are poor responder. And there are people who are still going for a long agonist protocol for poor responder. There is no reason to shift to antagonist protocol. I do mini long protocol. Some other time we will speak about it. What is mini long protocol? I give a very minimal dose of a down regulation, and then only on day 6, I jump out once the cohort has rescued to the good level of 20 units or so. Now, women with endometriosis can be reassured with regarding the safety. They always have a feeling that if I have an endometriosis and you are doing an ART, am I going to be at a more harmful stage than those who don't have? But you can reassure them that the ART can be safe. Only thing is, always think that these women have a high chances of developing the pelvic infections. So have a protocol in your ART center to put this patient on an injectable antibiotics. I always keep, if it is, I'm doing a ART for level 3, level 4, or presence of endometrioma, even if I have not entered in, I always keep this patient in-house 3 days after the pickup just for the injectable antibiotics, because I have so many my endoscopic friends, Sanjay Patel and all, saying the amount of ovarian abscesses post pickup, they do the surgery, they get the references. I think life is not enough to do all the complication by yourself. Learn from others, and that's the reason to avoid these ovarian abscesses formation, which is a dreaded complication. Believe me, it's impossible to do the laparoscopy in those pelvic abscess. We spoil their entire obstetric career, their personal quality of life as well. Might as well we admit them for 2 to 3 days and give a prophylactic coverage. Are medical therapies effective as an adjuvant for endometriosis? Which are the medical therapies? Long-term GnRH. The extended GnRH as such is not recommended to benefit. It is insufficient evidence to recommend prolonged administration of CC pre-treatment to ART. But let me tell you, if we are doing level 3, level 4 endometriosis ART, we should be doing a frozen embryo transfer because, as we say, there is an increased pro-inflammatory cells, wrong interleukins, NK cells, lymphocytes. What is important is this Th1 immunity has to be shifted to Th2, and pre-transfer IVF GnRH therapy definitely will improve your results. Women who received GnRH for 3 months have a lower concentration of follicular fluid cytokine, and these women also have higher fertilization rate. Now, friends, after vitrification 2008 onward, our frozen embryo transfer cycles have increased. But when we used to use slow freezing as a technology in early 2000 or late 90s, what we used to do is we used to give a 3 months GnRH, then we used to do their IVF and the fresh embryo transfer. Why we used to give a 3 months pre-IVF GnRH? To increase the oocyte better quality and to optimize the implantation, make the hostile atmosphere into the favorable atmosphere for implantation. However, when you give this pre-IVF GnRH, implantation rate, embryo quality, or clinical pregnancy showed no statistically significant. You may have lesser number of top quality embryos, but the embryo quality in those who are present, whatever, there may be 2 embryos, 4 embryos, they will be of a great quality. So there is no difference in a live birth rate. Are surgical therapies effective as an adjuvant prior to ART? I have already spoken. It is not recommended. There is no additional benefit. On the contrary, there may be a negative impact on a ovarian reserve. Only thing is, deep infiltrating endometriosis, whereas there is a severe pain. If it is a very good surgery one has done, which caused complete removal of the disease, extensive, and then reperitonization has happened, there may be a natural conception of 28%. Surgery for endometrioma and deep endometriosis prior to ART should be considered only for the pain or accessibility of the follicle, otherwise no. What non-medical management? What non-medical management? No medicine, no surgery. Actually, there is no recommendation. There are no evidences whether certain type of diet or Chinese therapy or acupuncture or electrotherapy, psychological intervention, whether it is going to help. There are no evidences, so it is unclear. Is endometriosis an indication for fertility preservation? Why I'm taking this? Because we all believe. Sometimes I feel 35-year lady, if I'm doing a frozen embryo and I'm doing an endometriotic surgery for her pain or some reason, and only because she's not planning the pregnancy to get her off, I feel like I should take some ovarian tissue and we should do the ovarian tissue cryopreservation because she's elderly, she may have a recurrence, she's not planning the pregnancy. I might as well do her ovarian tissue cryopreservation. Why I'm talking about this? We all believe in, we all recommend to our patient, but a very interesting article in 2020 by Garcia. See, Garcia, Tulandis, they have done a huge work on endometriosis. You will find their huge publication. I don't know if I send infertility study such publication, it will never get accepted. But what they have said is oocyte cryopreservation is expensive and it exposes women to some clinical risk. And the evidence says that you should discuss the pros and cons of the fertility preservation with the woman of endometriosis, and the true benefit of fertility preservation still remain unclear. Sometimes I feel they may be right because the ovarian tissue, whatever we cryopreserve, if her pelvis is so damp frozen, where you will do the reimplantation and when you will activate, whether it will get activation. Though we don't know Dones and all their studies with the forearm implantation, but still, when we are talking about this, it's very important how we are talking in onco patients. Same way here, oocyte cryopreservation, I should be talking or not is the time. The time will answer. Garcia's publication says no. You discuss with the patient and let the patient decide. So, friends, to conclude, in infertility, individualization of each case is important in order to ensure your excellent result. Tremendous understanding of pathophysiology is a must when you are working on an endometriosis patient. You should know the decline in an AMH, the rate of a decline, irrespective of a surgery, and the time you have in a hand. Early reference to the ART expert will help to avoid the recurrence and time interval to the pregnancy. If surgery is needed, expertise in the field is mandatory. First surgery has to be the best surgery to avoid the recurrence and to have a spontaneous pregnancy chances post-surgery. Very important. Treating endometriotic patient is challenging. Always remember, we need to thank each and every challenge because it builds your strength and character. Over 3 decades operating patients, explaining, understanding their pathophysiology. I think endo, ART, and high-risk obstetric. Recently, I have heard a very interesting talk of Dr. Pratap Kumar, pregnancy after endometriosis, and it's eye-opener. So you need to have your team of a high-risk obstetrician also who will be carefully managing this very precious pregnancy. Friends, before I end, let me appeal all of you that I'm contesting for the Foxy Presidency 2023. And I request humbly to all of you to support and help me to achieve my another dream come true. Thank you so much. Thank you. Thank you.
Thank you, Dr. Sunita. It was really wonderful, and you stressed the all important points in endometriosis. Surgery is the best treatment before IVF, and first surgery is the best surgery, and you have to do a good job like you always do. And you also explained the role of progesterones in the dydrogesterone and how IVF can lead success within first 6 months of surgery. Even deep-rooted endometriosis, deep infiltrating endometriosis, if you do a good job, then there can be spontaneous pregnancies also. I'm not sure whether Dr. M.G. Hiremat will be able to do the question and answer session. Maybe he's traveling, so it is difficult. Dr. Kasturi, you may conduct that. We were thinking of allowing the audience to directly ask you the questions. Before that, Kasturi.
Yes. No, it was a really very excellent session, Dr. Sunita. Excellent. Lots of practical take-home messages. I know endometriosis is such a big dilemma, whether, especially in these young people, whether to operate, not to operate before she conceives. I mean, so many people will be in dilemma. Can we go ahead with like simple conservative treatment, then try and all. So, but you gave us so much clarity on this. And excellent. That's within 6 months. That too, after laparoscopy, most of the people like after surgery will be thinking, asking them to conceive after 4 months, 6 months because they undergone surgery. But they'll be losing the most precious time. Like generally, I feel people are telling them you've undergone surgery, so it's better you conceive after 4 months.
And you know what, Murli, I give for only drug available was Dufaston and 10 milligram OD dose because it has to be cost effective also. I used to give routinely, means even today I give, but without even understanding this, only because we all knew that the dydrogesterone is an immunomodulator. And that's why, and we all know that immunity is at in a trouble in a endometriotic patients. So I used to give dydrogesterone routinely even before I used to do the ART. I entered in ART in 2000, but even in early 90s, I used to give dydrogesterone as a routine to all these patients. It never causes anovulation. That's the most important thing.
There is a question by Dr. Yukti, and she is asking, how do you compare Dynogest versus dydrogesterone?
Okay, Yukti, very good question and good you upon this topic. Dynogest will cause will not allow the pregnancy to happen. Okay, thinning of the endometrium, everything will go back. So here our aim is them to conceive. While dydrogesterone, as I told you, immunomodulator role, it will make completely these pro-inflammatory NK cells all shift from Th1 to Th2 immunity. And on the top of that, they don't affect the HPO axis. So you are not stopping her ovulation. Please don't give a dynogest. You are making them then infertile.
Okay. There's one more question by Dr. Jairam Nambiar, who was my former colleague in Manipal. He's asking, most ordinary laparoscopic surgeons will not be able to do excision of the deep infiltrating endometriosis. In such cases, are they justified in just doing a simple surgery for endometriosis of ovary?
If that patient has a deep infiltrating endometriosis, and especially if she is in a severe pain, just don't do only the surgery. Please get expert endoscopic with you and do the job. If the expert endoscopist come, believe me, even the DIE patient can conceive. As I showed you, 28% chance of a spontaneous pregnancy. So I don't think we should do any half-hearted surgery in an endometriotic patient. Yes. Also, there is one question by...
I'll ask that. Dr. Rasha is asking, is it necessary to check AMH after the laparoscopic removal of 7 centimeter endometrioma in an unmarried?
No. What is very important is you have to do pre-operatively. You should do her baseline AMH before you go for her surgery. But when you do the unmarried 7 centimeter, believe me, first is I might cancel 10 unmarried before I take a 11th unmarried girl for a surgery. I will sit with them. I will counsel with them. And 22, 23 years, imagine she's not going to get married for 7-8 years, and then she will have a recurrence. So I will try and work as much as possible with the medical line of treatment. Here you can think of giving a dynogest to that patient. Give dynogest for 7 months, 8 months, no harm. Please keep on checking her bone density scan and avoid doing surgery in all unmarried unless medical line of treatment fails to relieve their pain. Number one, golden rule. If you have to operate, see to it that you are expert. Third, you have done preoperative AMH. And fourth, you sat with the patient and given a very good counseling about endometriosis remaining with her life till the menopause. The early marriage and early planning of the pregnancy is her gold standard. Fifth, she needs, till she gets a marry and plan the pregnancy, very regular checkup with you. Just don't tell her 2 years OC pill. She should be following with you every 6 monthly. And you should follow with the two things, her AMH and her sonography. By now, her virginity has gone. When you have operated, you should do the transvaginal sonography, because deep infiltrating endometriosis, pelvic endometriosis, very difficult to catch up by per abdominal. And if it is still not possible, then you do the per rectal sonography for these. So unmarried endometrioma, please, please, please don't operate as much as possible.
That's an excellent advice, and it could come from such an experienced person like you only. And I totally agree with you on that, because it is always better to avoid surgeries unless you are planning to go for a infertility enhancing treatment, or if it is so distressing to her. Always you can postpone it.
I will like to tell you one example, sometimes how painful it is. One lawyer, she's highly educated and most beautiful lady I have seen. She can go in a film acting, unmarried stage endometriosis. Okay, she had undergone laparoscopic appendicectomy, and that time they found her endometrioma. I told them nothing doing. It was a level 4. I was treating her with the medical line of treatment because it was asymptomatic. I pulled her for 5-6 years. Ultimately, she got married. And I went for my family friend's son's marriage, and I saw she is the bride.
Good.
I went and I saw her, she saw me, and I see whatever it is, we have to help and protect the identity of our patient. I am deep mouth and they are not planning pregnancy. And I don't know how to, but this is a very, when I saw her, I said, oh my God, I just gave her all the best. But I know she's going to need the ART for a pregnancy.
Sure. And there are so many complimentary messages. Dr. Vidya Tobi, who is the
Oh,
president
Vidya is here. Hi, Vidya.
president-elect of
Hi, Smita. It was
Hi,
excellent.
Vidya. Lovely
Bangalore,
to,
Yeah.
lovely to have you, Vidya. Lovely. She is our president-elect of Kasoga.
yes.
I'm sure Kasoga is going to go up and up and up. The excellent state it is going to become.
Yeah.
Thank you.
Thank you very much.
And
Thank
we would like you to see, visiting Kasoga in a higher capacity.
Yes. All the best. All the best,
Thank
Sunita.
you. I'm so happy. I'm really very much touched that entire South India is with me. I'm absolutely humbled and touched with every state of South India. Of
We
course,
wish you all the
rest
best.
also.
We wish
Rest
you all the
also.
best, and we are with you.
Thank you, dear. Thank you. Thank you for an opportunity.
Yeah, I think there are no more questions.